Hello and welcome back to HBI 2020. Next, we're going to be looking at investment opportunities in emerging markets. Now, this next section was pre-recorded, but as ever, of course, all of our guests are happy to take any questions, so just pop them in the chat section. Okay, let's join the session.
Welcome to what I know will be a fascinating discussion on investing in healthcare services in emerging markets. An hour later at 11:45 a.m. UK time, you can have your say by joining our interactive roundtable, and that's a chance to talk in groups of 3 or 4 and to network and discuss your views on investing in emerging markets. We find that format of very small groups really forces everyone to interact and create something which is quite similar to the normal conference experience. So I very much hope you'll be able to join us there. So this is a fascinating session. Emerging markets, I think, have been particularly hard hit by COVID because healthcare operators there typically have lacked the state support that you get in many West European countries. And we also saw, of course, a collapse in electives, a big hit on healthcare tourism. So they've been hit hard, but underlying demand clearly remains high, and new digital solutions are on the horizon and indeed are taking off. So with this panel, we want to explore what the impact of COVID has been on businesses and valuations, and also what are the new business models of the future. We've got an absolutely great panel here today. Let me introduce you to them. Charles Dalton has spent the last 7 years flying around the globe, investing in healthcare services for the IFC, which of course is the world's largest investor in healthcare services. So he really knows the sector extremely well, and he's also got this global vision of it. Vishal Bali is the executive chairman of Asia Healthcare Holdings, the single speciality delivery platform of TPG Growth. Over the past 4 years, it's built South Asia's second largest chain of oncology hospitals under the American Oncology Institute brand. And it is also now the largest mother and child speciality play in South Asia, with a chain of 12 motherhood, women and children's hospitals and 27 Nova IVF centres. He's also the founder of Nightingales, which runs home care and care homes in India. So he knows quite a lot about the elderly care market, which of course is fascinating in emerging markets. In his spare time, he's the non-executive director of the $1 billion Evercare fund backed by TPG, which took over from Abraj, I think, in 2018. And this, of course, was an extremely ambitious platform which aimed to provide healthcare for the multitude and to have a double book column thing, so that you're doing good as well as making money. So that is very interesting. And our third panelist is Dr. Amit Varma, who co-founded Quadria Capital a decade ago. It's invested $2.2 billion across the Asia-Pacific region, including in specialty hospitals, in home care, in LabLink, the largest lab group in Malaysia, and a stake in Healthcare Global, which is the largest oncology chain in India. So we've got a bunch of really expert and involved investors in healthcare services. We're going to start off with a very short slideshow from Charles, looking at how the IFC has seen COVID impacting the sector, and then we'll go into a panel discussion. Over to you, Charles.
Thank you, Max. I'm having a few issues getting the tab to come up, I'm afraid.
Oh, well, you can always ask Richard to go on to the next slide if you want to.
Yeah, Thanks. I'm going to have to. Sorry, everybody. The tab stopped. So thank you very much, Max. Thanks very much, HBI, for asking me to attend this presentation. So I'm basically going to spend a very short amount of time giving you IFC's views and perceptions on where we think the COVID impact has been on emerging markets. Richard, next slide, please. Okay, thank you. Thanks. So basically, I'm going to talk about 4 areas. The first area is that disrupted demand that Max had highlighted at the introduction. We're then going to talk briefly about the government sort of intervention, so how the private sector and the public sector has or has not been able to work together successfully on this. I'll touch on the supply chain related issues, and then I'm going to talk about the financial implications that have faced these health service providers in multiple markets. And I must state from the outset, there's no one country fits all. There are different experiences, different learnings from different countries. But as you'll see in the presentation, there are some underlying themes and lessons to be learned. Next slide, please. So the disrupted demand, let's just talk about the sort of the backlog. So in some markets, there's been growing concern over the backlog of care, and that seems to be a consistent theme that's coming through. So chronic care, NCD care, etc., etc. And it's not just emerging markets. We are seeing this in the developed world as well. So that's something we're going to have to watch very carefully. In 2021, there is going to have to be a catch up in some regard on that care, but it just depends how that's going to be managed and implemented, given that we have demand and supply gaps in many of the markets that we're working in. Definitely some elective care has been lost. I don't think some elective care will be captured back. So that on the elective side of things, that's going to be lost. And medical tourism, it's going to take a while to recover. It's been hit badly. We still have the travel restrictions. We still have specific countries requiring what you need when, certain tests to get into the country, or you're not allowed into those countries. We don't think medical tourism will recover to the back end of 2021. And we've just got to see what happens with the vaccine rollout. So there has been a revenue loss. That's very clear. What we've noted is 2 months of major revenue loss for health service providers, up to 70% during the respective lockdown periods, if I can call it that, in a country. And it's taking plus minus 6 months to bounce back without the wave 2. So we're seeing wave 2 in some markets, and we haven't got to wave 2 maybe in others, and we're watching to see what happens. But it's taking about 6 months to sort of bounce back to where hospital, labs, primary care providers were prior to that. But it does vary per market. But we are seeing the defensive nature of healthcare. And this is a consistent we've seen in other recession-like activity in the past. The healthcare sector, the private healthcare sector, is pretty defensive because people are still needing access to healthcare services. But we think we're going to see return to financial positions pre-COVID at the back end of 2021. So it's going to take a while for recovery to happen. And also one thing that we've noticed, COVID income does not offset revenue from other services. So for those private sector players that have been able to offer COVID services, that income gain, if I can call it that, has not offset the main losses they've made from this chronic care, the NCDs, etc., etc. Next slide, please. Government intervention. This is a really interesting one. And we, from an IFC perspective, are very pro, and we really support the increase and utilization of public-private collaboration. We think to strengthen healthcare systems, we need more public-private collaboration and better management. But what we've seen in many markets, the public sector still doesn't have the mechanisms in place to engage with and contract with the private sector. So this has highlighted some gaps that are going to need to be addressed over the next few years as we move towards social health insurance, as the need for public and private contracting increases. It definitely seems to be a gap. Contracting has started, so it's looking at price, its volume, quality, and transparency. There's definitely an expectation that if I give you volume, you give me price. There are a couple of markets where it has been done in terms of the contracting. South Africa has been one of those. And also, it's not just COVID care that this contracting has been taking place for. Some governments have got a backlog on their chronic care as well, and there have been some examples of the private sector being asked to take on some chronic care workload, but only in a few countries. Next slide, please. The supply chain, absolutely, it's been disrupted across the board. What we did see initially was price hikes, quite considerable price hikes for a number of goods and services related to COVID, so PPE, ventilators, etc., etc. The trend seems to be going back to normal. So the initial price hikes went up, and the prices are now coming back. But there does seem to be a elapsed time delay for ordering goods and services. And so again, hospitals are having to plan more in advance, more forecasting, more awareness of the sort of limitations of that supply chain. We are hearing, for example, about delays at customs or at ports as these goods come into specific countries. So that we're going to have to watch very, very, very closely. As I've said, the ports and the customs are delaying the access to some of these goods and services, but prices come down. Next slide, please. The financial implications, I mean, this is where we spent a lot of our time looking at our portfolio and engaging with other third parties outside of IFC as well. And there have been some liquidity issues. So to us, it's highlighted the importance of active cost management and performance analytics. Quite often when we look at entities in emerging markets, understandably, they've been focused on revenue, but they may not have had in place the good performance analytics, the good cost oversight, and the ability to manage when things go slightly astray, as we've seen recently. So what we have seen, there has been headcount reduction in some markets, or a percentage of salary saving in some markets as well, and also large-scale expenditure has been delayed. But those groups with the better focus on cost and performance analytics appear to have been able to respond better than others. CapEx programs have definitely been delayed. So there's been a push out of some large-scale CapEx for existing hospital groups into 2021. And so also we've seen some greenfield projects have been delayed as well into 2021. Unless there's been a specific COVID-related infrastructure development, and some hospitals have had to do that to separate services, build ICU. But on the main, a lot of the big expenditure initiatives have definitely been delayed. Next slide, please. So overall, and in conclusion, the market dynamics with COVID, it's a mixed bag. So there is definitely an increased focus on quality, patient safety, and value for money coming out of this. Questions are being asked about pricing, but also questions are being asked about quality and better access. We are anticipating increasing labor restrictions in some markets. It's not been easy to move people between markets, and we know we have a healthcare shortage. So I think this is healthcare professional shortage. So I think this is something we're going to have to watch really closely over the next 18 months, because I think we are going to see in some markets access to healthcare professionals, the challenge is actually going to go up. We also are seeing investor reflection in some markets, not that they're going to exit, but they may be taking a little bit longer to make a decision about entering a market or expanding within a market. Definitely, and this isn't really linked to COVID, this is a general observation, and we do know over the next decade, we're going to see an increase in private health insurance as the middle income and corporates grow, but also linked to that, we're going to see a big growth in social health insurance. So that's also going to play into the need to look at the role that the private sector plays and how this private public collaboration and can work, and the expectation on maybe a business model shift in some markets for the private sector. There may be some immediate M&A activity out there, because we do see some groups maybe getting themselves with liquidity issues, and it may release some M&A activity. Financial resilience strengthening, that's going to be required, and increased interest in primary care and out of hospital services. We knew this going into COVID, that there was a shift coming in the market. What we're now definitely seeing, that it's not all about hospitals. We need to look at what I would call, the easiest way to call it is these ecosystems. We need to look at healthcare as a system, and where do we best provide that access to care for the patient? And it doesn't necessarily have to be in that hospital. So how do we take care out to the community, if that makes sense? Increased use of telemedicine, absolutely. I mean, digital health was here before COVID. It's now exploded during COVID. And the opportunity is to harness it and grow it, but it needs to be embedded into the systems. Telemedicine operating in a silo is tough to make commercially viable for an investor. We need to look at how we embrace telemedicine. The increased use for data assessment. Data assessment in the healthcare sector is poor. There's lots of data. It's collected, but it's not used in the right way. So we need to look at how we use data to look at population, to look at disease, to look at access, et cetera, et cetera. I've mentioned about the whole healthcare system. We think there will be some infrastructure realignment. You know, groups may start looking at where are we going to put the hospital? Where are we going to put the supporting clinic? Increased investor oversight. I think there's a lot of lessons here, and some investors will have learned from their portfolio that they may have to take the magnifying glass out just a little bit more in the short to medium term on some of their assets. And then the key thing here on healthcare investing is there's going to be limited quick wins. Healthcare, as we all know, is a longer term game with longer term horizons, and maybe for investors, that shifted a little bit as the dynamics have changed over the last 12 months. Final slide, please. And finally, COVID has taught us no health system has got it right. So I'm not sitting here advocating that a health system A or country A has got it right. I think we can see from a developed world and emerging world perspective that everybody has got some challenge. But it's all about strengthening healthcare systems, to remove silos, improving coordination and promoting value, and increased opportunity for the private sector with the right business models. The future requires the private sector to step in and step up and look at how they can strengthen these healthcare systems. Thank you very much.
Okay. Thank you very much, Charles. That's a very interesting overview on it. Perhaps we can start really by asking the other two panelists what their experience has been with COVID and what lessons they've learned from it briefly. Amit, what are your views on how it's affected you?
Well, thank you for the opportunity. And Charles, that was a very well put summary on what we've been facing. But just to add on and maybe be a bit contrarian, I view this pandemic as an opportunity to become smarter in healthcare. There are a lot of things that took place which have accelerated the way we deliver healthcare. So as soon as the pandemic hit, because we didn't know much about it, there were three things we did for our company. We wanted to make sure that our company survived. That means that they had enough cash to last. The arbitrary nature of lockdowns ensured the fact that a lot of our patients could not access healthcare even if they wanted to, because it's not like heart attacks and strokes suddenly disappeared. And the third, as you alluded to in your slides, was the gravity of shortage of the supply chain. So basics like gloves and masks disappeared, which is something that we had never imagined in our lives. I think as the initial shock went past and the first 2-3 months went away, we realized that this is here to stay. This is not a one-off effect and things will go back to normal. This is going to stay. And then we started to fine tune and ensure that the safety, security of our staff, mainly frontline workers like nurses and doctors, had to be paramount. And the entire operating efficiencies came into play. So we had COVID beds, but we stopped, we limited the number of non-COVID patients, and we started looking from the other perspective. But I think to me, the biggest benefit of all of this is the following. Number one, this is accelerated digital healthcare, and I'm using the term loosely, has accelerated digital healthcare by 10 years. Suddenly, telemedicine, the importance of electronic records, the importance of point of care testing, diagnostics has become front and center. And for those of us who've been struggling in this field for many, many years, this is something which is welcome. The second thing that happened was that you took the opportunity and you cut away all the inefficiencies that we had built inherent systems by pretending that those are sacrosanct and you can't touch it. So you could go to doctors and you turn around and say, now guess what? You don't have these 3 operating theaters because these are not COVID proof. And they bought into it. Otherwise, if you went to a cardiac surgeon and said, I'm going to start doing orthopedics in your operating theaters, there would be a riot. So those kind of small incidents came into play. I think the third most important one is what we realized is the role, especially in emerging markets, on how you treat infectious disease. We had gotten so caught up in dealing with chronic diseases that we had forgotten that acute infections still play a massive role in our lives. I think the amalgamation of what we do in secondary and tertiary care, linking it to what we do in primary secondary care, which is linked to diagnostics, point of care testing, the focus on predictive, and lastly, which is the interesting part that I'm beginning to believe in, is as tertiary care experts, we had de-linked ourselves with primary care, which is predicting disease, and left it to local governments because as tertiary care providers, we didn't care. And for the first time, what the pandemic has done for us is that we are linked to the community. We have to ensure that we have a healthy community. So we can't wait for the disease to hit us. We have to be part and parcel of the most abused word in healthcare, public private partnership, and be an integral component of ensuring that we are part of the diagnosis and treatment in the community and not wait for them to come to the hospital.
How do you do that?
So I think the whole telemedicine network, the fact that we were able to create teams of getting diagnostic kits out there, integrated business models of now running remote outpatient networks, and most importantly, leaning on to the general practitioner networks in rural and semi-urban areas to make them part of our systems was a very, very important part. So instead of leaving those guys out there in the boonies, asking them to take care of all the stuff, but if they needed transplants, then send them to us. We were part of that integration. And Charles also mentioned a very important point. We create terabytes of data. Quite unfortunately for us, we don't do much with it. So because nobody asks us to, and insurance, especially in emerging markets, doesn't put pressure on us to look at outcomes and look at how we can predict disease, we've kind of left that alone. That, to my mind, is something that we are changing. And now you have business and analytical teams going through data, figuring out how to make us smarter and be able to predict disease before it hits us.
Right. It's fascinating, isn't it, how telehealth seems to have grown. And when I talk to people about it, that they will say that when patients have tried it, they want it again. There's sort of 80, 90% of them say, yes, I want more of that. So it's really here to stay, isn't it now? I guess.
Max, and I want to give you if I may, I want to give you a live example. As COVID hit, we started doing a large number of X-rays and CT scans because that's one of those things that you use to make predictive scores on how severe the disease is. Quite obviously, there is no country in the world, whether it's the US on one end of the spectrum or to emerging countries, where you have enough radiologists to go through reams of data. And we quickly started using artificial intelligence at the back end, embedded in our machines, to start doing the screening to at least get the normals out of the way and let the radiologist focus on the scoring part of it. And that is being done in most of our hospitals. We always had the ability, we always had the technology, we never used it. And suddenly now, because of the overwhelming number of scans, this became front and center and something that we did it as normal. And this, going forward, is going to be the new normal.
Yes, yes. Okay, that's very interesting, isn't it? And Vishal, What about you? What has been the learnings for you? I mean, in COVID.
Yeah, so I think we've had a very interesting 6 months, right, Max? And as Charles and Amit alluded to, I think this period has actually taught healthcare providers a lot more than what the previous decade really provided them in terms of learnings, and particularly related to operating efficiency, right? So we all know that healthcare, whether in emerging markets or in the developed countries, is a high capex, high opex burn kind of business, right? And it takes a long time for healthcare enterprises to actually get to break even, then to get to operating margins, and then to sort of hit that 20-25% EBITDA margin that we all underwrite ourselves to. So I think one of the big things that happened during this time was we saw convergence of patients and the appreciation that patients had for better clinical environments. I think that was one very big learning, which also from the consumer perspective, was very, very apparently felt, and particularly in some of our own portfolio companies. So like, for example, as you said right in the beginning, we run the largest mother and child platform in this part of the world. And we saw that, many of the mothers who were about to deliver and were also going to many other healthcare environments as a part of their, 9 months of pregnancy and follow through, actually converged into the motherhood hospitals, basically because we were following the CDC norms, the WHO norms, the safety norms, in order to make sure that our hospitals were not impacted as much by COVID as some of our competitor organizations, and particularly the ones which were finding it very difficult to offer safe environments because they have not really built that safety culture. So on the back of that, we saw, not just on the women's side, which is on the women's healthcare side, but also in terms of we operate close to almost about 150 NICU beds, for newborns and for premature babies. We saw the outbounds coming into the environment, basically because parents wanted them to be in safer environments, and also their gynecologists and pediatricians and neonatologists wanted to treat these babies in safer environments. On the back of a lot of this operating efficiency work, we saw our portfolio of the hospitals grow organically. In fact, while we have seen many of the other healthcare enterprises degrow during this time, we actually grew at this time. And in fact, we had almost a 17-18% year-on-year organic growth inside.
Really? What, on the mother and child side and on oncology?
On the mother and child side, yeah. And we actually graduated almost close to about 350 newborns from hospitals which were from smaller nursing homes where the babies were actually sent into the motherhood NICUs, and on the back of this entire COVID situation, which has also sort of made a massive impact in the way that our operating margins have changed. So, our group was actually operating at operating margins of about 48-49%, which actually went up to almost 52-53%. At the EBITDA level, we have seen growth of almost about 60% on the back of this growth, and also on the back of the operating efficiencies on all the costs that COVID taught us, that you need to look a lot more internal than external, right? And as Charles rightly said,
you're saying your EBITDA increased by 60%.
Right. And that's basically because, we saw a big throughput of revenue. We looked at a lot of our operating costs and said, why do we really need this operating cost? And we skinned out a lot of operating costs of the system. And that really helped the entire operating efficiency of the model. Frankly, if I was a year back looking at the same parameters, I would have not made many of the changes that I made inside this portfolio at this point in time. Because when life is normal, you tend to make a lot of investments behind the future. But I think COVID taught us that we have to look at present and here and now, right? And this cannot just go on for the next 3, 4, 5 years. So in the quest for survival, I think many healthcare enterprises learned many new lessons, right? And they also learned the lesson of capital efficiency. which I think is paramount for this particular sector. So I think overall, yes, Max.
Yeah. So okay. So I mean, how about working with governments though, guys? Because what I've heard from other people in emerging markets is that it has been very difficult and quite chaotic in many countries, and that perhaps much harder than in a country like Germany, for example. That it's been a case of the government taking initiatives and suggesting things without really getting the buy-in of the private sector, and then them not being able to implement them, and that it's been really chaotic. Is that your experience?
Yeah, so I think Max, what has really happened is that the governments around the emerging markets were completely caught unawares
Yes.
in terms of, as it is in the emerging markets, public healthcare spending has been abysmally low. And
Yes.
all these emerging markets have actually grown on the back of private healthcare and funding which has come through private investors in terms of making their healthcare infrastructure grow. So the first reaction was that governments didn't really know how to handle the epidemic and the size and scale of the epidemic. And as is always true, the first thing that the governments look to is control pricing, get into regulatory mechanism, try and control the throughput of beds. And that's really what happened in the emerging markets too. And, if you take a look at all the countries in South Asia, the entire push was that how can the private sector come and help us and deliver better quality of care so that we can look after patients who've been impacted by the pandemic. I think those conversations then got into the price control and trying to then control prices around COVID treatment, not looking at what it costs to sort of manage and look after these patients. But I think the way that the private healthcare institutions, the role that they play in emerging markets, during the COVID situation, a large portion of the government activity also got supported through the private enterprises. Amit wanted to say something.
Yes, Amit.
Yeah, I just wanted to add on to that, and be a bit more controversial than Vishal is. You're normally a very polite guy. I think governments in most parts of our regions did a phenomenal job when it hit the fan. So the first few weeks were wonderfully done. There were lockdowns, curfews, people actually following orders. This was a unique thing for our part of the world, where public was actually following what they were told to do. But I think, as Vishal rightly pointed out, as the weeks wore on, the arbitrary nature of the bureaucracy started to creep in. And whether it was price cuts or telling us how many beds we could open or not open, who could get admitted in an ICU, and it was suddenly getting decided by people who probably have a limited understanding of healthcare. And that led to a situation where I think there was a lot more intent by the private sector to want to contribute to the pandemic community, but was getting bogged, which is the main issue in our part of the world when it comes to bureaucracy. So in arbitrary, just to give an example, 48 hours ago, the governments in Delhi suddenly decided that the RT-PCR test should be one-third the charge that they'd been charging 48 hours ago. No concept provided, no context, and suddenly it's out there. Now, at this point of time, while I understand that you want to increase the number of RT-PCRs, should not that be a discussion? Should that be a diktat? And that leads to the disconnect between public and private. Now, I know IFC does a phenomenal job of straddling both public and private, and Charles will have his own view on it. But to me, I think it's incredibly important that if there's one learning that we have as we go forward, public cannot survive without the private sector, and the private sector has to be the support to the public sector, but we have to do it as friends. It can't be an adversarial relationship.
Charles, what are you seeing around the world in this area? Are you seeing, give us examples of one or two governments who've got it right?
Yeah, look, it's been, I'm not going to, I don't think there's any particular government that I can say has got it 100% right, because there have been issues. I mean, some governments have made a concerted effort to try and figure out how they can better embrace the private sector. And I think the most immediate example that comes to my mind is in South Africa, where the South African government in some of the provinces have contracted with the private sector for for services. And my understanding, it's been at a lower tariff that the private sector has been used to. So there are pockets of these examples out there. But I think maybe the more important point here is we're at a reflection point now. And it's highlighted that the public sector needs to figure out how it can work with the private sector. There's a recognition that the private sector does provide core services that can support the government. But what it's also highlighted, unfortunately, that health still operates in silos. And there isn't enough integration across that. And the governments need to be strengthened to be the custodian of the overall healthcare system. And it comes back to some of the earlier points that were raised. I mean, the use of data, better planning, building trust between the public and the private sector, looking at new contracting models between the public and the private sector. We have to figure out how we bring the public and the private sector together in these different markets to build these long-term sustainable healthcare systems that consist of both public and private, and the private is able also to support the public. I mean, a common challenge has been the trust issue between the two sides, if I can call it that. But also, a lot of the time, the public sector is contracting for short periods of time. So for the private sector to make investments to then support the government in short periods of revenue flow, that's not a good business model for the private sector. So we need to help governments look at where are our demand points, where are the supply gaps, how can we contract with the private sector for over longer periods of time for set volumes of work, and then we can start building that trust. So I think
at
COVID
reasonable
has highlighted
prices.
how we need to change. Yeah, thanks.
Yeah, Amit, what do you think about that idea? Do you think it's going to happen, or are you skeptical?
I think that would, yeah, I think that would require
It sounds
an enormous
nice.
amount of, it requires an enormous amount of trust, emancipated politicians, less greedy private sector, and too many things to point in the right direction. It sounds great, and I wish we could do it. It's just that the pessimist in me of 35 years of trying to do this in emerging markets makes it hard. Though I do want to point out here.
I'm not saying it's going to be easy. I'm not saying you could do it tomorrow. It's a long-term game.
Yeah, but I think there is a growing realization that we cannot work in silos. We have to survive together. I think there's one area that we should work in tandem is predictive diagnostics, point of care testing, and the private sector taking a lead role in preventive healthcare rather than just waiting for people to create patients. I am extremely worried about what the pandemic has done to chronic diseases. And I think we are sitting on an epidemic of chronic diseases. There is going to be a torrential flow of cancer patients, kidney patients, heart patients who have ignored care or ignored chest pain and have sat at home because they're worried about COVID. One of my most given examples that I keep talking about when I hear about all the worry that people like, let's say in India, have about COVID deaths. India does 4,000 tuberculosis deaths a day. Have we ever shut down a country for 4,000 deaths? The answer is no. The reason is because these are chronic deaths. And my big concern here is that we are going to see this kind of a chronic patient disease pattern over the next few years, which is going to be extremely hard for us to control.
Yes, so a big increase in that. Just looking at the sort of financial impact of all this. I mean, I think when we were talking about this earlier, Vishal, you were saying, for example, that COVID had seen a collapse in medical tourism, and that this meant that you were changing. I think but all of you were changing your attitude towards Africa, and seeing a greater willingness to invest in Africa because you realise that you need these countries now, like Nigeria, and recognise that they really do need these facilities there for the elite, because if the elite can't leave the country when they're ill, then there is going to be a healthcare system in the country. Would you like to talk about that a bit, Vishal?
So, Max, I think, as we've seen, even in this part of the world, which is the South Asia part of the world, the Southeast Asia part of the world, that over a period of time, as countries develop, their healthcare systems develop. And as their healthcare systems develop, they get new technology, they get a lot of private funding, which basically helps the entire setting up of new healthcare infrastructure. New medical technologies come over there, that the clinicians tend to come back to those countries from wherever they had gone. So there is a net import of talent that begins to happen in these countries from the export of talent that used to happen a decade or 2 decades back. And I think COVID has actually demonstrated even more than ever before that countries again have to start thinking about their own healthcare infrastructure first, start looking at creating better quality of infrastructure, better quality of clinical talent, grow more doctors and nurses through their medical colleges and paramedical colleges, and basically create their own healthcare ecosystems, and also strengthen their own healthcare ecosystems, because it is true that from the sub-Saharan African countries, from many of these South Asian countries, patients have actually been traditionally over the last many years, until the time countries like India and obviously Singapore used to be a big hub in Southeast Asia. Thailand was a big hub in Southeast Asia in terms of patients, and international patients going and getting treated over there. Particularly from many of the African countries and also European and American countries. So I think,
and it's really changed your view on investment, hasn't it? You're now looking much more actively, aren't you, at African countries? Is that right?
Yes. So in fact, we are strengthening our presence in Kenya. We are the largest providers under the Evercare Health Fund. We are the largest providers of healthcare services in that country. We are strengthening even more. In fact, over the last 1 year, there are 3 new hospitals that our group has started in Kenya. In Nigeria, which has sort of not seen a new hospital for the last almost 15 years now, we are launching a new state-of-the-art tertiary care hospital. We have invested almost close to about $65 million behind that enterprise. It's a 300-bedded state-of-the-art hospital, which goes up on 1st of February. So I think there is this thinking now that let's strengthen healthcare ecosystems in emerging countries, and why not provide as good a healthcare for people who are trying to access them in other countries, in their own countries. And I think international travel, frankly, Max, is not going to resume to normalcy the way that I see it, at least over the next 2 years. I think we are very, very far away from international travel to sort of resume to absolute normalcy the way it was pre-COVID.
2 years? Because I think the IFC was saying that you thought it would be the end of 2021, didn't you, Charles, or were you?
Yeah.
Yeah, we're getting back to normal by the end of 2021. So absolutely, into 2022 is we'll get the full recovery. Thanks.
Yeah, so that's a long way off.
It's a long way off. And so what's going to happen to all the patients who are crisscrossing the world trying to get healthcare? I think this is the time to actually put in more capex inside these countries. This is the time to invest behind better clinical talent inside these countries. This is the time to strengthen their ecosystems. And I think this is probably a great time for all the investors to come in and start looking at some of these emerging markets, or markets that we had sort of left open for a very long period of time on healthcare investments to actually strengthen.
And are we seeing an acceleration in smaller groups getting out? I mean, is it the case? I mean, you were saying, I think, that it's the case that as a larger group you're in a disadvantage. And so is this going to lead to a rationalization in the sector with some family-owned businesses going, oh my God, I just don't want to do this any longer, or it's just too stressful? Are you seeing that happen, Charles? Do you think that's going to happen, or?
It may happen in some markets, but I think we need to understand that the demand-supply gaps are so large. I think we still will see, standalone hospitals, smaller family hospitals. But we are definitely seeing and this was pre-COVID, we were definitely beginning to see in some markets this realization that a standalone hospital on its own isn't the future, that we need to broaden the group out, either by adding additional hospitals or
Yeah.
putting in what I would call the spokes that feed those hospitals. So the business model mindset was beginning to change. I think in some markets, yes, standalone hospitals will still be there because there's nothing there. But I think
Yes,
as the
nothing
markets
else.
mature,
Yes.
we get more towards this integration. If I could just make one last comment on the medical tourism, I think there is an opportunity for medical tourism going forward. Currently, a lot of the medical tourism is about how do I get a patient from Nigeria to go to the Middle East or go to India. What hasn't really happened is saying how can I have an international hub that works with local players in Nigeria, in Kenya, or wherever, supports those health professionals and looks at how they can treat the patient back in the home country and provide that support when required from that hub elsewhere. So I think where we may see is there's a joining of the dots for medical tourism. It's not just about flying the patients in and out. It's how you can create a system to support a country that doesn't have enough healthcare professionals, but give the patient confidence to stay, knowing they're being supported internationally. If I'm making sense, thanks.
Yes, it does. Yes. And Amit, what do you think about this? Are you seeing a ration? Do you think there's going to be a rationalization?
Yeah, just let me. No, I just wanted to add a couple of points that both Vishal and Charles alluded to. I think there is no debate to my mind that there is going to be an acceleration of investment in local countries. So for us, for example, we get a ton of patients from Indonesia, Vietnam, and Philippines into Singapore, where we are incorporated. And now we are going to accelerate our plan, maybe by even 200, 300%, of starting to provide local care in these countries instead of waiting for patients to come to us. But I think the challenge that we should speak about is the lack of infrastructure and the lack of talent. It's not just about going and building capex out there. You don't have the specialists, you don't have the doctors, you don't have the nurses. And I think Vishal said it right at the beginning. This has to start at a base level where you start creating manpower and you start creating the talent. It's very easy to go build a bed. I just don't know how to staff the bed. So I think what's going to happen now is an acceleration of existing. And coming back to your point, Max, it's not just buying out the moms and pops. Unfortunately, the quality is abysmal. So it's easier to go in with an established player in that market and get them better. And I'm talking from the private sector rather than try and build everything greenfield, which takes its own sweet time. So the next 2-3 years, I think is going to be incredibly exhilarating. There will be new models. We will get more efficient. There is more capex going in locally. But if you ask me as a doctor, my great wish is to be able to do primary and secondary care locally, but still export the tertiary and quaternary care, because it's going to be very hard, and that's the honest truth, for me to start doing liver transplants in Nigeria. That's not going to happen.
Right. Yes. Okay. Vishal, you had a...
Yeah, so I think, Max, if we were to sort of summarize some of this, right, and what we are already seeing across various sectors, so there is a massive reshoring which has begun to happen, right? So if you look at, active pharmaceutical ingredients in the pharmaceutical world, people are turning around and saying, why do we need to continue to get our API from China? We will go back to doing our own API. The medical devices businesses are talking about, why shouldn't I do more indigenous creation of medical devices and medical technology? Healthcare services providers are turning around and saying, I will treat patients in my own country, right? And I will strengthen our ecosystem. And clinicians are now beginning to say, and this is our own experience, Amit, that, when you start building out healthcare infrastructure, you do see some of the clinicians turning around and saying, fine, I'm happy to, give up my practice in the UK or the US. If I really see a big opportunity of growth over here. And that's where we're seeing some of the clinicians even come back to Nigeria from the UK and the US. So I think we are going to see a massive push around reshoring, which will strengthen countries and strengthen the healthcare systems in those countries. And this is a broader healthcare, right? It is not only on the hospitals and diagnostics, but even on the pharmaceutical and the medical devices side. So I believe that the next couple of years is going to be very sharp in terms of localization, in terms of indigenization of technologies. And, all the countries like India is trying to talk about indigenization of its medical devices. We are going to see a lot more localization. And also there is this crisscrossing has sort of, which we saw even during the COVID time. Germany actually turned around and said, medical technology for our citizens first, and then to the world. I think we are going to see a lot of this. So I think, see this to be a great time around building and strengthening local healthcare systems.
Yes. Yes. Okay. So, I mean, and sort of finally, to bring an air of vulgarity to the conversation, what's happened to valuations then? I mean, so you're not seeing a lot of distressed assets coming onto the market as a result of COVID, and for you, Amit, valuations remain too high, do they? I mean, I remember Abrar, your partner, telling us how awful it was that multiples were still at sort of 30 times, and therefore it was very difficult to actually make any purchases. Is that still the case, or are we seeing any drops in that kind of thing?
So, to stay with the vulgarity, valuations in healthcare continue to be obscene, a bit distant from business reality. There are no
Yes.
distressed sales that I'm aware of. There are a few companies who have cash flow issues and are willing to have dialogues which are a bit more meaningful. But people have hunkered down, people have learned to live, and as Vishal rightly pointed out, all of our healthcare facilities, both in pharma, life sciences, healthcare delivery, healthcare at home, all of them are beyond pre-COVID levels. I wish I had the same margins that Vishal did. My revenues are, my margins aren't as outstanding as his are. But business is back, and business is back with a boom. And
Business
I
is
don't
back with a
see
boom.
why they should be. And just remember, healthcare valuations in our part of the world are crazy because of lack of quality and not enough of
Yes.
them there. That's it. It's a scarcity demand issue. So I don't
Yes.
see those changing. Hopefully now, COVID will make them realize, and especially when people are looking at selling, they'll hopefully see that they need to be grounded in some reality. I don't know, Vishal, if you're seeing something different.
Right.
Yeah.
Okay.
Yeah.
Yes. So, and
No,
Charles,
so I think
any thoughts on that?
sorry, Max. Yeah.
No,
So
go
I
on. Go on.
think I think FY21 has been a washout year, right? So for many of the healthcare enterprises, or even in the larger ecosystem of various industries and sectors, companies will probably, now begin to look at FY22, and those who sort of come back and show the rebound inside their enterprises, as I said, both on the revenue and the profitability side, I think will continue to play the evaluation game there, but there will be others who have not shown any kind of movement in terms of creating the efficiency that is required, and probably those companies are going to get devalued based on the FY20 valuation. So I think we are going to see a very interesting 2-year run here in terms of how companies perform and where they go from there. So FY22 is really going to be a very, very interesting year for healthcare.
22, yes. Okay. Fine. And Charles, do you want the last word on?
Yeah,
on
no. If I
valuation?
can just add. I mean, I'm not going to really. I've got nothing to change the dialogue coming through. I mean, I still think valuation levels are relatively high in most of our markets. We haven't seen a massive downward shift in valuation. I do believe you have a couple of good groups, and I'll come back to the quality in a minute. A couple of good groups that are operating at high quality, and you could argue they may warrant those valuation levels, but I think there's a number of other groups that are hanging onto the tails, and the valuations are inflated compared to their value they're adding to the actual care. But overall, there hasn't been that shift down. There still is that high expectation level on valuation. But just the last thing from me is the quality angle. It's come up a couple of times, and I think we must emphasize that what we're seeing with COVID is there's this patient wants confidence in the quality. The healthcare professionals want quality, so they'll come back into the hospital once they're happy that the quality's there, as with the patient. So I think what we're also going to see is this drive towards improving quality as well. And to me, if we can do that makes these businesses more sustainable, more attractive, etc.
And more
Thank you.
worthwhile. Right. Okay, well, I'm afraid we're going to have to end it there, guys, because we have come to the end of our time. Do please join us, though, on the interactive roundtable, which takes place in an hour's time, I think 11:45 a.m. on December the 16th. so that you can join in and have your say in those discussions. So thank you very much, Vishal, Amit, Charles.
Thanks, Max.
It's been a very good discussion. Thank you very much.
Thank you very much.